This is a case of non-ST elevation myocardial infarction in a patient with left subclavian artery stenosis. So I would like to present this case to you as it came to us on the inpatient medical service. Here we have an 80-year-old female presenting for left shoulder pain. She has a past medical history of end-stage renal disease on hemodialysis and coronary artery disease status post-CABG. She's here for evaluation of her left shoulder pain, and this shoulder pain occurred during hemodialysis. It was also associated with lightheadedness, nausea, palpitations, and hypotension. The patient was found to have an elevated troponin and was diagnosed with an NSTEMI. Subsequent cardiac cath revealed patent bypass grafts. However, there was found to be a significant stenosis of the left subclavian just prior to the junction of the lemur. This was resulting in a reduction of blood flow. Alright, so on this slide here, you can clearly see the stenosis. We treated this stenosis with a bare metal stent in the subclavian artery, and medical management was then initiated, consisting of dual antiplatelet therapy, statin, and a beta blocker. Okay, so subclavian steal syndrome is an uncommon complication in patients undergoing CABG. The syndrome was first described in 1974 and can present as early as 1 to 2 years or as late as 31 years following the surgical procedure. The decreased or reversed blood flow causing this phenomenon predominantly occurs due to stenosis in the proximal subclavian artery. In most cases, the primary etiology is atherosclerosis of the vessel. However, there are other rarer causes including dissection, thrombosis, fibromuscular dysplasia, radiation, aberrant RCA, hemodialysis AV fistula, vasculitis, and neurofibromatosis. In our case, we suspect that hemodialysis increased the degree of steal from the subclavian artery, which then precipitated the event. Now, typically the common patient presentation entails chest pain, but patients with ipsilateral vertebral artery compromise may present with neurological deficits and claudication. The most common imaging modalities for diagnosis include CT angiography, MR angiogram, or coronary angiography. Definitive treatment consists of stent placement, which we proceeded with, or surgical bypass of the occlusion via a variety of techniques. Okay, so here are some take-home points. I want to stress that ACS from subclavian artery stenosis is a rare clinical entity, which in our case was precipitated by dialysis, exacerbating the steal phenomenon, presenting with cardiac symptoms, but it can also present with neurological symptoms. Diagnosis through angiography, and it's typically treated with stent or bypass. So on that note, I'd like to end this presentation by thanking you all for listening. I hope that this is a condition we can keep in our differentials, especially when we have patients with a similar presentation. And feel free to direct any questions to us via email. Thank you very much.